incorporate liquid biopsy testing upon cancer progression rather? Once a patient starts to progress, when would you use liquid biopsy testing? Dr. Hart? Oh, you're on mute.
I tend to send that when I first see the patient and they have some clinical evidence, either on a scan or an exam or by symptoms that they're progressing. When I think clinically they're progressing, I think that's a very reasonable time to send a repeat liquid biopsy. We all know that cancer is not stable genetically. Obviously, as Dr. Walker's mentioned before, patients can have lots of things come up. Certainly, I have plenty of breast cancer patients that have shown that they have evidence of what's called an ESR1 mutation, which is more and more recognized now, makes them resistant to aromatase inhibitor therapy. So they may be cooking along for a couple of years on an aromatase inhibitor and a CDK inhibitor. All of a sudden, looks like they're progressing and they have an ESR1 mutation. So there are other treatments they can go on, like fulvestrant, other things that would still potentially be efficacious, but aromatase inhibitors no longer work. So that's very, very important to know. And there's many other things that will show up too. So there's really no reason not to do that when, our rule is, generally speaking, that we'll biopsy at first progression. I generally try to do that across the board in most cancers when the biopsy site is accessible. So obviously, if there's something like a lymph node or something you can easily get to, we'll do a tissue biopsy. If it's going to take a liver biopsy or a lung biopsy to get tissue or bone, which is very problematic for getting good tissue, obviously, we will tend to send a liquid biopsy first. So most cases now I'm doing liquid biopsy first, and then I'm deciding later if I need tissue. That's my standard right now.
Thank you. Dr. Reeves?
I'm rapidly becoming of the opinion that you should do liquid biopsy testing at each progression. Now, if you do that, and there are some patients who are getting that these days, not a lot, but if you do that, then you're going to have a lot where the new one just tells you the same mutational pattern that you had before. But I think you're going to start picking up more and more changes in the molecular mutations that appear that will become actionable. And it's really interesting when you follow these serial cases where that happens. This particularly happens in the targeted realm. EGFR is a good example, where those patients, some of them will get the classic resistance mutations, some will get MET amplification, some will get other forms of progression, AXL expression, et cetera. And these things are rapidly becoming actionable themselves. Those alterations that are escape pathways for the initial EGFR mutation treatment. And so I think this is one of those things that's going to gradually become more and more important as we go further into this, as more mutations become actionable, and as patients live longer on the treatments that they're on.
Thank you. That's very interesting. Dr. Walker?
I again echo everything exactly from Dr. Hart and Dr. Reeves. A cancer's tumor biology is every time it progresses or recurs, there's clonal evolution. So it is a different cancer than it was at the beginning. And certainly upon any symptomatic or suspicious radiographic progression, it is important to reassess the tumor biology and the molecular findings. And a liquid biopsy is a very easy and reliable way to do that, because you can identify, as Dr. Reeves said, resistant pathways, or you can identify new oncogenic drivers that can make a difference in your management. It's also something, a recent study from Mass General did exactly that. They did plasma and tissue at the time of diagnosis, and the plasma identified more pathways than tissue, and the overall survival was not improved based upon the tissue findings. The overall survival was improved based upon what the plasma NGS was showing. So the liquid biopsy is really showing what the metastatic cascade and the metastatic clone is, and that's why it's so important to know that. And Bill, this question doesn't fully reflect it, but there's another evolving time that monitoring with the liquid biopsy can be helpful, and that is early into a treatment at the 6 to 9 week mark, just as we would normally image. It's clear if you have an EGFR, an ALK, and it clears, that's going to herald a long durability of control. Likewise, if not, things are going to recur much shorter within the median survival than expected. And with immune therapy, when PET imaging can be confusing, when radiographic responses can be very, very slow, an early decrease in the ctDNA can then indicate that a patient is responding, and then you just stay the course and keep going forward. And sometimes after a while of complete response, you can recheck it. And if the ctDNA is completely clear, then you know there's over a 90% chance that the cancer will not return. So it's an evolving clinical utility of liquid biopsies that's very exciting.
Yeah.
Any additional insight, guys?
Yeah, I'd like to just put in here, one thing that I occasionally see is people doing liquid biopsy testing at a time when the patient has already had a good response to whatever treatment that they're on. And I think this is really the wrong time to do it, because at that point, the patient's circulating antigens are going to be at their nadir, not at their peak like you would have at the time of progression. So it's just something to try to avoid doing. You might realize, I forgot to send the NGS, and so then you do it after the patient's had 3 cycles of chemotherapy. And if they're doing well on that treatment, then as Paul said, you're going to see nothing on your liquid biopsy because you've wiped it all out, at least for that time. So it's just a little mistake to avoid.
Oh, thank you for sharing. Anything else, Dr. Hart?
Well, one of the things I think in the future we may be doing at some, this is coming about more, there's more and more studies about this, is, obviously we have patients now who are doing great on immune therapy like checkpoint inhibitors, and are now perhaps 2 years into their treatment with clean looking scans, and we're thinking about stopping treatment. This is still a big area of controversy, discussions, clinical trials all over the place on, and I'm starting to see some data now that if your scans are, stable and looking good, and liquid biopsy is clean, and patients are able to discontinue immune therapy after being on it for a year or two, that the results are quite good. Now, obviously, we don't have, as I've always told patients, we don't have 10 years of data on this because you haven't been doing this for 10 years, but there's going to be more and more data. And I'm sure in the future, I would predict that there's a good chance that we will be using this as part of our decision-making process in deciding when we can de-escalate therapy, aside from just now we're using it when we need to change therapy when things are not doing well. In the future, I think we may be, and this is the very near future, and people are looking at this now, be able to use it to decide when we can de-escalate therapy also. It's very exciting.
Outstanding. Anything else to add, Dr. Walker?
Just one observation. All of our understanding and even the evolving best clinical utility of liquid biopsies and plasma next generation sequencing is still in its infancy. It was at ASCO, American Society of Clinical Oncology, in 2016 that plasma NGS finally bubbled up into discussions and educational symposia. So it's only been around for 5+ years, and we're rapidly seeing the advantage and the impact it has for patients living their lives longer and living their lives better with cancer.